Good evening and welcome back everyone to HKL RT series, Radiation in Hematological Malignancy Part 2. I'm Dr. Ananda Kumar Balakrishnan, Clinical Oncologist from Hospital Kuala Lumpur, and I'll be presenting now on primary CNS lymphoma. The most common histology subtype of primary CNS lymphoma is DLBCL, and immunodeficiency is a major risk factor. It's mostly male predominant, 2 to 1 in general population and 9 to 1 in the immunocompromised patient. Radiotherapy is now mostly used as part of a consolidative therapy after high-dose methotrexate-based chemotherapy regimens. So HIV accounts for 15% of non-Hodgkin lymphoma cases, and majority is actually associated with EBV virus. HIV-associated primary CNS lymphoma is also classified as AIDS-defining and is much more difficult to treat, but the incidence of this disease has reduced significantly with advances of combined ART. So systemic therapy in primary CNS lymphoma is mainly based on methotrexate. So high-dose methotrexate is the backbone of primary CNS lymphoma treatment. So the common regimens that are used is MTR, we have matrix, we have RMVP, RMVBP. So there are several methods of consolidative therapy in primary CNS lymphoma. The first being myeloablative high-dose chemotherapy followed by auto stem cell transplant for patients who have actually achieved complete response from methotrexate-based chemotherapy. So this is a treatment option for patients who are young and patients who are healthy otherwise. And the outcome is actually comparable to patients who receive a whole brain RT 36 to 45 grays as consolidation, but definitely less significant neurotoxicity. The next option is something related to us, radiation oncologists and clinical oncologists. So reduce dose whole brain RT consolidation for complete response and partial response. So for patients who have complete response, 23.4 grays in 1.8 gray per fractions, and with an additional of boost up to 45 grays to the residual disease for patients who had partial response. So excellent ORR and PFS with decreased neurotoxicity as compared to patients who had 45 grays to whole brain RT, and is currently used for patients who are poor candidate for auto stem cell transplant. So the next option of consolidation is non-myeloablative high-dose chemotherapy for complete and partial response. This is usually offered for patients who are young and even in elderly patients as well. The last option is actually maintenance chemotherapy for complete response. So these are for very, very poor candidates who are not suitable for high-dose chemotherapy, transplant, and also radiotherapy. So agents that are used in maintenance for primary CNS lymphoma are high-dose methotrexate itself, rituximab, temozolomide, procarbazine, lenalidomide, and ibrutinib. This is just to prolong the progression-free survival and to preserve the quality of life of this already ill patients. I'm going to talk a bit about the radiotherapy dose evolution in primary CNS lymphoma. So first trial, RTOG 8315, 40 degrees of whole brain RT with 20 degrees of boost to the tumor bed. Actually still had high recurrence rate, but the median was only about 12 months, median OS. So the RTOG 9310 showed the discovery of high-dose methotrexate, which became the backbone of induction chemotherapy in primary CNS lymphoma, and followed by 45 degrees of whole brain RT, gave us about 30 to 40 months of median overall survival. The next trial actually showed induction chemotherapy with high-dose methotrexate consolidation whole brain RT with 45 grays increased the PFS, but no OS benefit as compared to HD high-dose methotrexate chemotherapy alone. And they also discovered that the whole brain RT arm actually had significantly increased neurotoxicity. The MSKCC trial showed that induction chemotherapy with reduced dose whole brain RT, 23.4 grays, actually shows high response rate with long-term disease-free control and minimal neurotoxicity as compared to all the previous trials. RTOG 1114, the latest RTOG trial, showed that addition of reduced dose whole brain RT improved the PFS of primary CNS lymphoma without significant increase in neurotoxicity. So for radiotherapy planning in primary CNS lymphoma, there are a few things that we need to look into. We need both pre-chemotherapy and post-chemotherapy MRI. An eye examination is really crucial with a slit lamp to determine whether there was already involvement of the globe. Pre-chemotherapy, if it is involved, then the whole brain RT should include the entire globe to a dose of 30 to 36 grays. CTV for primary CNS lymphoma, the whole brain should be included up to the first and the second cervical vertebra. Posterior aspect of the eyes I usually include half or two-thirds of the posterior globe. The isocenter should be set anteriorly. This is it's a 3D planning. Anterior border of the PTV needs to be set with the isocenter 5 mm behind the lens. So if the eyes were originally involved, like I have said before, we have to include it in the entire whole brain RT field. So this is an example of how we do it in 3D. So we need to include those inferiorly up to C2, the entire cranium, include the frontals, medial temporal fossa as well. But I will open up a bit more at the globe. So dose for radiotherapy in primary CNS lymphoma, if whole brain RT is offered for monotherapy without prior induction uh, chemotherapy, so 36 grays in 18 fractions, whole brain RT followed by 9 gray boost to the primary tumor. If it is post-chemotherapy and the patient has achieved complete response, then whole brain RT 23.4 grays in 13 fractions. If it is partial response, then whole brain RT and followed by 12.6 grays in 7 fraction for boost to the primary tumor. So if this patient is planned for palliation, so for fitness reasons, age and whatnot, so we can consider a dose of 30 to 36 grays in 10 to 15 fractions. So thank you. That's all for me on primary CNS lymphoma. See you on the next presentation. Thank you.